Okay, so good afternoon, everyone. So let's have our recap of our discussion. Alright, let's have a recap of what we have discussed accordingly with the topics on the diagnostic process. Mhm. It is very important for nurses to eventually consider how how data and information of the clients will be validated accordingly based from the condition. And from the presenting signs and symptoms, we will be guided accordingly on what could be the prescribed treatment, preventive measures, and um, rehabilitative regimen will be done or will be prescribed to our clients. Nurses must have the knowledge, the skills, and attitude when it comes to interpretation of diagnostic examinations because primarily these are considered as foundation on how you will deal with your nursing care management efficiently and effectively. We have uh, we have discussed accordingly of what do we mean by diagnosis. Diagnosis, as what we have mentioned in the previous discussions, that it's considered as an evaluation, and merely uh, from the presented signs and symptoms, from the results of the laboratory tests and tools, the evaluation and the identification of the specific disease will give us a clear direction on the appropriate treatment and follow-up test to validate the actual results of the diagnosis of the client. Diagnosis could be initial, could be confirmatory diagnosis, because the initial diagnosis, if we do not have yet the supporting documents or supporting results of diagnostic examinations, and we just relied on the results of our physical examination findings from the presented signs and symptoms, from the primary data that had been recorded. So that would be a working impression or initial diagnosis. But once all the results of the diagnostic examinations are in place, then that may give us a higher level of approach when it comes to confirmatory diagnosis. So a clear direction is very important so that to prevent either complications and to have a focus on what specific treatment can be done to the client. And diagnosis can be supported with what we call diagnostic examinations. The diagnostic examinations are examinations, obviously, are procedures, are specific and systematic way of evaluating the weaknesses and strengths to determine the condition. If we have talked about the weakness, the weakness is we are referring to the specific area wherein if there are definitive and distinct findings, then it will give us the direction to specify the treatment regimen. The strength is that of if there are no identified distinct health problems and conditions, but the client could be high risk, vulnerable, susceptible to a certain disease or illness, then it will give us measures on how to prevent due to the early detection. So that's what we call with the weakness and strength. Actually, diagnostic parameters are of importance because for nurses, this will give us significance in our significance and importance when it comes to the essence of our responsibilities in attending to our clients. The number one importance that we have mentioned was importance of diagnostic parameters is diagnosis. And we have identified here that the key importance is appropriate treatment. Okay. So if the client had, from the presented signs and symptoms is supported by the diagnosis, then it identifies the specific disease. And if it identifies the specific disease, then it will lead to the course of appropriate treatment. And it will give us also the direction of what specific tests or further tests will be the second phase of the diagnostic examination to go deeper or to go in depth of the affected systems, organs, and physiologic response of the body. So diagnosis is all to know specifically the appropriate treatment. When we talk about the monitoring, we're talking about the key term here is control. Okay, to specifically having the intention of controlling. Okay, the monitoring as an importance, as one of the importance of the diagnostic of test parameters is to are applicable most commonly in the chronic diseases. And the chronic diseases that I have identified in our previous discussions are diabetes, autoimmune diseases, chronic kidney failure or kidney problems. These are conditions that may need further routinary monitoring so that to support and avoid uh, development of complications, to to avoid systemic effects, and to avoid untoward physiologic response. So just like for example, as a chronic disease, we have given an example in diabetes that blood sugar are being monitored if chances that the client will be subject for administration of insulin, or if it is controlled, it is not anymore necessary for the administration of insulin. Just like for the clients with kidney failure, hemoglobin, hematocrit are being monitored routinely so that if it is necessary to administer erythropoietin. Erythropoietin is a drug that are given to clients with kidney failures so that to prevent risk for bleeding. So next, number three, importance of diagnostic parameters is all about screening. For screening, the key term that we may identify here is all about clustering. And why we do the clustering so that uh, this could be more specific when in terms of the population groups. Okay, one of the examples that I gave to you is the screening on the COVID-19 test. And based on the COVID-19 test, it may identify the subjects or the individuals who could be dependent, the clustering could be dependent on the presented signs and symptoms. It could be mild, moderate, or severe. So the clustering of the clustering of the results specifically may give measures on the specific groups. So that's why this is applicable on the large segments of population. Next is all about prognosis. Prognosis, as defined, are the chances of recovery of clients, or the chances the client may be low risk or high risk in developing complications. As the patient's predisposition when it comes to if the client has familial history, then this could be also taken into consideration. So for example, one of the example, I think the example that I gave to you here is about the cancer, which eventually when the client is subject for biopsy, it may further identify if it is malignant or benign. If it is malignant, then the next step for further test is to identify what stage. Okay. And based on the stage of cancer, accordingly, this will give the idea on how the healthy members will have the treatment regimen and care management to the client, which is, for example, if the client is on stage one who may have breast cancer, then the client may prevent metastasis or spread of the cancer cells through the nodes through surgical management. For stage four, it may not be the same as treatment for the stage one because most of the stage four cancer may identify the metastasis already of the cancer cells to the adjacent systems or organ. So most probably the level of the immunosuppression may be different from stage 1 up to stage 4. So the prognosis is very important for the nurse to significantly identify preventive measures and to become realistic on what specific care management could be applicable at the time that it is detected on the specific stage of cancer of the client. So those are the four importance of the diagnostic parameters. Last time also, as emphasized, the diagnostic exams as an important tool for nurses to basically identify direction and focus to give focus of treatment to the client. Now, one of the diagnostic exam that I have presented to you is about complete blood count. For the complete blood count, this is very basic yet very important. Okay, I will emphasize this to all of you future nurses to at least have the mastery on this interpretation, because every time that you proceed to any healthcare facility, complete blood count is the number one test that will be considered as a primary and foundation, as baseline, so that to support what specific treatment could be done. And this could be very helpful when it comes to the analysis in the pathophysiology, because this may identify bacterial, viral, inflammatory, parasitic, uh, hypersensitivity, allergic reactions. So the results may give us the idea. For example, if we have a result of decreased uh, reference on the RBC. So we are aware that it could be anemia. But there are still types of anemia that we may consider. So that will be more focused. Is it a nutritional deficiency anemia? Is it sickle cell anemia? Is it anaplastic anemia? So this may have different approach when it comes to treatment regimen. And nurses must definitely know this basic foundation. Next, what are the components of the complete blood count? So we have mentioned we have red blood cell, white blood cell, and the platelet. Red blood cell is also called as erythrocytes. The white blood cells are also called as what? Leukocytes. And the platelets are the what we call thrombocytes. Now, to take into consideration what are the complete blood count, the complete blood count could be with or without differential. With is it includes results of the 5 types of WBC, which we have mentioned in our previous discussion. So if it is without differential, it may only have results of red blood cell, hemoglobin, hematocrit, WBC, and platelet count. If it is with differential count, then that may consider the 5 types of WBC, which are the eosinophils, the neutrophils, the basophils, the monocytes, the lymphocytes. And the specimen that are being extracted for the complete blood count, as what we have mentioned, is peripheral venous blood. So obviously the blood is coming from the peripheral vein. And usually the preparation on this is once the blood has been extracted, it will be placed in the tube with the what we call anticoagulant, because we all know that blood once exposed outside the blood vessel may lead to the possibility of clotting. And clotted blood may not be considered as a valid specimen for testing. So that's why as an acceptable specimen, clotted blood or clotted specimen greater than 48 hours may not be any more valid for testing. So that's why upon extraction of the blood, it may contain the tube may contain the anticoagulant EDTA, and it's mixed, okay, so that to prevent the clotting. But if the blood have already clotted, then it should extract again a specimen for test. So these are for the red blood cell. For the red blood cell, it is erythrocytes. The lifespan of red blood cell is 120 days. Okay. Red blood cells are being produced by the bone marrow. So that's why every time that we have problems with the bone marrow, red blood cell is the one that are being evaluated. Now, these are the tests under the components of the red blood cell. Total red blood cell count, which is the RBC, hemoglobin, hematocrit, mean corpuscular volume, and the red blood cell distribution width. So the total red blood cell count, or the RBC, will be monitored accordingly as the general component of the RBC. The hemoglobin will basically be monitored because the hemoglobin is the one that is considered as the oxygen carrying, okay, oxygen carrying component of the RBC, and hemoglobin is considered as 90% of the component of the red blood cell. Hematocrit will be considered and determined as the blood volume. The mean corpuscular volume is the relationship between the volume and the size of the red blood cell. The red blood cell is determined accordingly as an average volume to also in association with the size of the red blood cell. Now, we have discussed accordingly that the hemoglobin concentration, if there's decrease in hemoglobin, the interpretation is anemia. The increase in hemoglobin, the interpretation is polycythemia. However, as what I have told you, if there will be decrease in the hemoglobin concentration, it is just simply generalized as anemia. How can we determine accordingly the specific anemia? That will be determined accordingly to the mean corpuscular volume. So these are the possible interpretations, okay, when it comes to hematocrit. So as what I've told you, hemoglobin could be associated with the oxygen carrying. So that's why if there will be decrease in the RBC, it may have a direct, obvious results also of decrease in the hemoglobin. Since we have mentioned it's 90% of its component. So decrease of the hemoglobin will be distinct as anemic. So ibig sabihin, this may lead to a possible results of hypoxemia. So hypoxemia meaning hypo, decrease, oxy, oxygenation, emia, blood. If there will be increase in the hemoglobin, so there will be an increased level of oxygen in the blood, so that would be leading to the problem with the hyperventilation or increase or possibly oxygen toxicity if the case may be. So when it comes to the hematocrit, as what we have discussed, this is related to the percentage of the blood volume as made up with the RBC. So if we are talking about the blood volume, if there we may refer to the viscosity of the blood. If there will be decrease in the hematocrit, then there will be low viscosity of the blood, low volume of the blood. If there will be increase in the hematocrit, so there could be chances of the increased viscosity of the blood, clotted blood, or possibly this may lead to the increased viscosity of the blood volume. So these are the possible findings if there will be decrease in the hematocrit concentration. So if the client may have loss of blood, what do you mean by loss of blood? If the client experiences profuse bleeding, for example, for those pregnant clients who are experiencing risk for abortion or miscarriage. So kung if there is increased blood loss, or if the chances that the client experience stab wounds and there will be internal bleeding. Okay, if there are damaged organs, internal organs that may lead to internal bleeding. So loss of blood may decrease hematocrit level. Other than the decrease hematocrit is depending on either abnormal hemoglobin or nutritional deficiency. So most of the nutritional deficiencies that we have identified are iron, vitamin B, and folate, which is very common. Okay, very common for pregnancy. So another is if there are bone marrow problems, so expect decreased hematocrit and sickle cell anemia. So that's the difference. For sickle cell anemia, this is anemia because of the abnormal hemoglobin. But for nutritional deficiency, we are talking about the level of iron, the vitamin B, and the folate. So if there will be increase in the hematocrit concentration, this is referring to poly. This is polycythemia. That is polycythemia rubra vera. Okay? The polycythemia rubra vera if there is increase in the blood volume. Okay? So possibility that if there will be polycythemia, too much viscosity of the blood may lead to the clotting of the blood. So that's why it's very harmful if there will be increase also of the hematocrit, because chances that if there will be increase in the viscosity of the blood, chances also that may lead to the possibility of clotting of blood and may cause the possibility of obstruction of the blood vessel. So another is if there is an abuse of the erythropoietin. So what is the erythropoietin? Erythropoietin, as what I've told you, is the drug that is indicated for the clotting. But if it is abused, it may cause the clotting and may cause the increase in the viscosity of the blood. So these are the results, the possible interpretations if chances that there will be decrease in hematocrit and increase in hematocrit level. Now, when we talk about other than hematocrit and other than hemoglobin, the mean corpuscular volume will give us more specific results when we talk about the type of anemia. Okay, so this is related to the volume of the blood and the size of an RBC. So in the results of the classification of anemia, we could have normocytic anemia, microcytic anemia, macrocytic anemia. So meaning, if we are talking about micro, small size, macro, large size, or exceeded to the normal size. Normocytic is normal size, but decrease, okay, this decreased distribution of the red blood cell. So if there is normal mean corpuscular volume, normocytic anemia, Decreased mean corpuscular volume are those that are identified as microcytic anemia, and increased mean corpuscular volume are macrocytic anemia. So we have identified last time what are the normocytic anemia, microcytic anemia, and macrocytic anemia. So the normocytic anemia, we have mentioned normal size, okay? Normal size of red blood cell, but there is decreased production. So still anemia. So these are the anemia of chronic diseases. So what are the anemia of chronic diseases? So these are the anemias from autoimmune diseases, these lupus, uh, problem with problem with chronic kidney problems, anemia brought about by hemolytic disorders. Yan. If we talk about aplastic anemia, this is the term anemia that are being identified that there is normal size of blood size but decreased production. So that's what you call aplastics. There is a difficulty in the production of the RBC. So probably one of the concerns here may have a relationship with the bone marrow. Now, micro. So for the microcytic and macrocytic, if you will notice, the type of anemia that are being identified are nutritional deficiency. Okay? So micro is more on iron, increase in MCB, macro are more on vitamin B12 and folate deficiency. So that's why it's very easy for the pregnant clients to identify if the client or pregnant client is anemic. It's very important that the results of the MCB may direct the pregnant client if it is iron-based treatment or treatment on the folate or treatment with the vitamin B12 because of the results of the mean corpuscular volume. Now, when it comes to the red blood cell distribution with so we are just having a recap, the distribution with or the RDW are expected that there's elevation. Okay, there's elevation with iron, vitamin B12, and folate deficiency. So, for example, we have identified in the mean corpuscular volume, most of the identified anemia are nutritional deficiency, iron for micro, macro is for folate and the B12. But when the RBC or when the red blood cell distribution with is revealed, it is expected all micro and macrocytic anemia are elevated RDW, except for one microcytic anemia. One microcytic anemia, which is thalassemia. Okay, what is thalassemia? Thalassemia is genetically or inherited blood disorders. Okay, blood disorder, which could be inherited from generations. The concern here is that of it's microcytic anemia, but the result is normal RDW. Okay, unlike for the problem with anemia of iron, B12, and folate, the result of RDW is elevated. So we have identified also the WBC. So the WBC is leukocytes, and the leukocytes are eventually considered as our defense against the infection, inflammation, because the WBC are WBC can be uh, found through the lymphatic system and tissues as well. Now, as basic to the natural defense of the body, if there will be decrease in the number of WBC, it's leukopenia. If there is increase in the number of the WBC, it's leukocytosis. It was presented that if there will be low WBC count, remember class, most of the concern if there will be decrease in the WBC count are more on the problem with autoimmune diseases. Okay? What do you mean by autoimmune diseases? Autoimmune diseases such as those who may have lupus, HIV, severe infection, or those usually or taking medications and may lead to the immunosuppression. Okay? So when it comes to the immunosuppression, there are immunosuppressive drugs such as chemo drugs, and other drugs as well. So radiation therapy and chemotherapy are immunosuppressive procedures also. So expect them to have low WBC. How about for, and that's what we call leukopenia. For leukocytosis, we have a high WBC count. Usually, if there will be increase in the WBC count, this is an indication of infection, inflammation, yan, yung mga itis, itis, inflammation, leukemia, okay, extreme increase in the WBC count, extreme stress, kasi the cortisol that are being released by the body hinders the immune system. Kaya every time that you will experience stress, expect WBC is increasing because it's related to the immune system and most the medication side effects. So the next question is that there will be increase in WBC. We're thinking of infection, inflammation, but what type of infection? So what specific inflammatory concerns are being addressed if we have this result? So that's why we have the what we call WBC differential count. Okay, the WBC differential count uh, WBC differential count could be helpful to basically identify if, for example, infection, if it is viral, bacterial, parasitic, okay? If it is more on allergic reaction, there are WBC differential count which will be significant findings. If there are inflammatory responses, then this could be identified also by the WBC differential count. In general, if we talk about infection, okay, infection, it may not identify bacterial or bacterial or viral. Monocytes is one that could may have significant increase if it is related to infection. The next thing to check is what type of infection. Okay, so this is now how you will do it. Eosinophils, if it is parasitic, parasite, the infection is caused by parasite. Significant increase in neutrophils if it is bacterial. If it is viral, the elevation in the percentage is lymphocytes. So it's clear. So for general infection, we can refer to the monocytes. For parasitic, eosinophils. For bacterial, neutrophils. For lymphocytes, viral. Now, how about for foreign substances? If we talk about foreign substances, these are, for example, the client had catheter, the client has tubes that are inserted to the body, so chances of traveling of the microorganisms and chances of infections. So monocytes could be one of the reference if there are existing extensive infection. Now, if we talk about inflammation, okay, inflammation, for example, the client may have bronchitis, the client may have tonsillitis, the client may have endocarditis. So, inflammatory. Remember, the one that are responding to inflammation among the WBC differential count is basophils. So what you will do, lalo na if there are asthma attack, because in the asthma, remember, the inflammatory process exists due to the narrowing of the airway passages. It's due by inflammation. So the basophils, inflammatory conditions, so expect if there are findings in the basophils. Now, we have identified, how about allergic reactions? So for allergic reactions or hypersensitivity, you will check basophils. So if you will notice, for asthma, if exposed with allergy, then narrowing of the airway passages caused by the inflammation, basophils. Okay? So these are the guide that you will have the mastery. Class, I will emphasize this to you because this was very helpful foundation and fundamental concepts that I have learned when I had my entry level as a staff nurse in the hospital. And this helped me a lot to develop my confidence when it comes to attending to the clients based from the diagnosis. So on the platelet count, if we are talking about platelet count, we are talking about clotting and bleeding. Then if there decreased number of platelets, there is thrombocytopenia, and if there's increased number of platelet, we have thrombocytosis. And class, remember, in the platelet count, if there will be low platelet count, expect risk for bleeding. If there will be thrombocytosis or high platelet count, expect for clotting. So these are the two that you must take into consideration. So that's why if there is dengue hemorrhagic fever, then expect if there is continuously decreasing of the platelet, there's a risk for bleeding. Okay? So if you will notice, viral infection is indicated to lowering the platelet count. So any viral infection may lower platelet count. Okay? So another is chemotherapy, bone marrow issues. Another for leukemia and inflammatory or specific blood loss, then the high platelet count for blood loss is a response of the body. So however, this must be taken into consideration for monitoring. Okay, so those are the topics that had been covered in the previous discussion. Now, we will proceed to the topic for today, which is all about urinalysis. And the question so far from the previous topics as a recap? Okay, if none, I will continue. Urinalysis again is one of the basic tool to help us on how to identify health problems connected to the physiologic response of the body. Every time the client may have the CBC, that the follow-up could be stool exam or urinalysis as well. But very common is the urinalysis. So this is a valuable tool to identify if there is problem with urinary tract infection. Urinalysis can also identify problem with liver and gallbladder. Urinalysis may also identify problems of risk for diabetes or ketoacidosis and other urinary infection. These are the components of urinalysis. Hoping everyone or most of you have seen urinalysis results. And these are the components that you need to know and interpret so that it may give us the idea on how to lead on a specific prescribed and appropriate treatment. So you may have findings of blood, which is red blood cell, which is not expected in the urine. Bilirubin or urobilinogen, nitrites, leukocytes or WBC, which is an indicative or indication of problems, possibly of infection, protein, ketones, and glucose. The protein, the ketones, and the glucose could be one of the reference of chances that the client may have possibilities of endocrine problems such as diabetes mellitus or possibly with other type of diabetes. pH is considered as the concern if it is acidic or alkalinic. So the acid-base status or level of the urine. And 2.9 rather is the specific gravity. So before we proceed with the specific components of the urinalysis, let us start first on the type of analysis, okay? The type of urine collection that nurse may engage to so that to facilitate results and will be essential findings that to support the specific care management of the client. We have the 24-hour collection. If you have seen in the slide, we have the container that is used. Okay? That is used in the 24-hour collection. Actually, for the 24-hour collection, obviously 24 hours it will be collected and the specimen will be refrigerated so that it may not contaminate the specimen for collection and for the actual test. Actually, class, the 24-hour urine collection is indicated on the following. If there will be abuse on steroids, okay? If there will be extensive infection, so that to identify specifically what microorganisms could risk the client for the type of infection. Electrolytes, because we all know for a fact that the kidney is the one responsible for fluid balance and electrolyte regulation, and to determine the urine osmolarity. The urine osmolarity is used to measure concentration of urine. This may identify that the urine osmolarity could be diluted or concentrated, which may identify the status of dehydration. So again, the 24-hour urine collection is used to determine chances of steroids, chances of the abuse of steroids, extensive infection, the white blood cells, electrolytes, which is very common. For example, to identify in the urine. Although electrolytes can be also be determined through the serum or blood, but this could be determined in the urine, but through the 24-hour urine collection. So urine osmolarity is the concentration. Now, we have the what we call first morning specimen. From the term itself, first morning specimen, it's the first void at the time of the day. And very obvious, it's in the morning. Okay? Uh, the first void could be best test for pregnancy. Okay? The best sample for pregnancy test. And if the doctor will tell you, it's the, please facilitate first morning specimen. So meaning the client specimen will be collected in the morning, and the client will be instructed for 8 hours in recumbent position, so that to facilitate the bladder, okay, the bladder urge, and to facilitate emptying of the bladder at the first time in the morning. So after 8 hours of giving instruction on recumbent position, then specimen will be collected, and that is the first morning specimen. Next, the fasting specimen is the second voided specimen after period of fasting. Okay, from the term itself, fasting, if the first specimen in the morning is first morning specimen, from the time that it has been voided, so it means again that the bladder is empty. When the time that it is again filled with the urine, the second voided specimen after the first morning will be considered as fasting specimen, which is eventually fasting specimen could be done accordingly when the client possibly may have a specific instruction of either no uh, drinking of fluids, or ano, fasting, from the term itself, fasting. So from the first specimen up to the second specimen, the client may not drink any water at all. So that is what you call fasting specimen. So I hope you it's clear when it comes to the difference of first morning specimen and the fasting specimen. Now we have the midstream urine. Most of the doctors I'm encountering this. Nurse, please collect the midstream urine. The midstream urine is used to specifically obtain urine for bacterial culture. Okay? And we all know that we need to have the bacterial culture to have to identify the specific growth of the microorganism, and to culture it, and check the sensitivity for purposes of antibiotic therapy. Okay? So how it will be midstream? The midstream is, for example, the first passage, the first volume, or the first amount, or volume of urine that will pass will not be the one being collected, but the middle portion of the voided urine is the one, not the last. Okay, not the last. So the first and the last will not be, but the midstream is the one that are being collected. Okay, so that is what you call midstream urine. Now, how about random specimen? The random specimen are being used for chemical and microscopic examination. So, from the term itself, random, just like unlike for the first morning specimen, the client could be subject for pregnancy test, so there's an indication. But for the random specimen, this could be used for screening. Okay? For screening purposes, for example, uh, the client is on the antibiotic therapy, and it has been identified that the client has urinary tract infection, the doctor may prescribe, or the doctor may order, oh, please perform the random specimen. So meaning the client will not prepare actually the nurse will not prepare the client, but eventually at the time that the doctor will collect it, then the doctor will mention it, then the nurse will can immediately collect the specimen for testing. And most of this are the we have the baseline results of urinalysis, and as a comparative if the antibiotic therapy are effective to the client's response. Next is we have the catheter specimen of urine. Okay. This is applicable if the client is on the Foley catheter, or if the client may have the problems with distension and may have straight catheter. The catheterization is very important for purposes of monitoring of the kidney function. Other than that, it could be useful also to specifically identify the distinct presence of UTI. Okay? Because we all know if the catheter has been inserted to the urethra, to the urethral canal, and passage it's a foreign it's a foreign body that inserted into the catheter. So greater chance that the client the microorganism may travel to the catheter. However, the catheter specimen of urine is used for bacteriological examination. So, sir, what's the difference with the random specimen? The random specimen is anytime the client may have the collection of specimen, but for catheter specimen, the catheter must be what do you call this, must have the distinct preparation, so it will prepare the client accordingly and kink the catheter so that to facilitate that the specimen that could be used will be effective for testing in the bacteriological examination. So usually the catheter specimen of urine are those that are used to really identify presence of UTI. Okay, next. Now, these are now the routine observation of urine color, and it is very important for all of us to be aware of this. I even introduced some of it during our pharmacology classes, and this is very significant for nurses, even though these observations and data, or observations rather, and data, yeah, objective data, this could be objective data, can be supported with the results of the urinalysis. But eventually nurses can have the initial interpretation on this. Example, the client who may have dark urine is indicative of dehydration. Okay, because dark urine, concentrated urine, is very obviously na the client is lacking fluids. Okay? Next, how about if the color of the urine is brown, green, or strong yellow? The strong yellow is the yellow that is very, very bright. Okay? But not luminous. That's different from luminous. Because if it is luminous, usually the luminous color of the urine is brought about by when you take about multivitamins, ascorbic acid, sodium ascorbate. So those are the color that are being produced. But the strong yellow that I'm talking about is concentrated yellow. If it is brown, there could be an indication of the presence of bilirubin. Remember, bilirubin is being synthesized by the liver. Okay? And bilirubin is significant when it comes to the breakdown of the red blood cell. If the color is brown or strong yellow, there's presence of bilirubin, and that's an indicative of chances of problem with liver. Okay? But it's not conclusive, ha? It's not conclusive. But at least the nurse may have the idea that the brown color or the strong yellow color of urine may have chances of presence of bilirubin. That's why chances the client may be subject for urinalysis so that to support any results of presence of bilirubin. Next, how about if the color is green? The green color may have the presence of Pseudomonas infection. Actually, Pseudomonas infection can be found Pseudomonas bacteria can be found to contaminated soil and water. And these are possibly the cause of pneumonia. Kaya if you've heard about Pseudomonas that may cause pneumonia, most of the antibiotics are resistant and very resistant sa in any antibacterial therapy. So very crucial if the cause is Pseudomonas. So the urine is color green, so expect possibly of Pseudomonas infection or possible excretion of cytotoxic drugs. What do you mean by cytotoxic drugs? If there are drugs that if the client undergone the chemotherapy and or either the client received a drug such as mitomycin. So that's why one of the consideration nurses that when you attend to client who are taking antibiotics such as mitomycin and if the color is green, so that's the result of having the mitomycin, other than if the client may have the problem with the Pseudomonas infection. Okay? Next, if the client may have bright red or red-brown color of the urine, then that's obviously hematuria. Okay? However, when female clients or students, if you will send specimen for urinalysis, please declare if you have menstruation. Please rule out if you have menstruation because this may cause a possibility of the alterations when it comes to the result and possibly may increase RBC. At least they may consider the blood there is blood streak in the urine because of the possibility coming from the menstruation. So you need to rule out every time that you will send specimen if you have menstruation. However, the presence of bright red and red brown as an indication of the hematuria could be found as a result in the urinalysis as well. Expect no RBCs. Kaya that's why if you will notice in the urine, 0 to 1 is the normal. And it's not expected because if there will be increase in the RBC, chances that there could be bleeding, there could be presence of kidney stones, there could be presence of crystals that may damage the tissues on the passageway of urine. So careful. Okay? So next, there are certain drugs also and food that may cause discoloration of the urine as an observation. One of which that influence the color is the beetroot. Okay, the beetroot is more in the Canada and I think if I'm not mistaken, yeah, in Canada. It's a root crop, purple color root crop that causes pinkish shade color in the urine. So that's why if there is pinkish shade color in the urine, have you eaten food with beetroot? Okay. So because that may cause discoloration of the urine. However, if the color of the urine is orange or red, orange, that's an indicative and ask the client if the client is taking anti-TB drug. Okay? Such as rifampicin. So these are very important observations of urine which may direct you on further tests. Kasi for example, if there is green, Pseudomonas, so chances check the client for urinalysis. Chances check the client for possible pneumonia. Check the client if taking mitomycin. If you have observed that there is dark urine, ma'am, check for signs of dehydration. So nurses will become more confident. Next, your urine is color orange. Are you taking anti-TB drugs? So if that information will be retrieved, it will be very helpful on how to give immediate response and attention to that specific client. Next, other than the observation, let us now proceed with the urine clarity. Or the clarity is the cloudiness. In a normal perspective, cloudiness can be identified but not harmful. Okay? Just like, actually, the cloudiness of the urine could be the presence of the mucus. Okay? Because possibly the tissues, sperm, prostatic fluid, or skin cells. So this could be the cause of the cloudiness. On the other hand, okay, if it is not caused, the cloudiness is not caused by the mucus, by the sperm, by the prostatic fluid or skin cells, it could be possibly the urine color are with white or red blood cells, pus or bacteria that may need attention. Usually, I saw these situations when the client is on the catheter with catheter and connected to the urine bag, and their presence and the urine are cloudy. Uh, I might think that it's pus. Okay, it's pus. So that's why the client may be subject for urinalysis. And if it is blood streak, then we could check primarily if it is coming from the irritations brought by the catheter or brought about by the problem with the bleeding. So that's why urinalysis is a definitive and confirmatory parameter to identify specifically the problem. So proteurine, if it is proteurine, it's bubbly. So signifies protein in the urine. The more the chances that it's more bubbly, the greater the chances that you could have a possibility of diabetes or high blood sugar level. Okay. So next, how about when it comes to odor? When it comes to odor, fishy smell and ammonia may indicate urinary tract infection. The acetone smell of the urine is presence of diabetic ketoacidosis. Okay? The ketones are the ones. Okay? The ketones must not be Actually, protein, glucose, ketones must not be part of the result of the urinalysis. Why? We have a large we have the glomerulofiltration barrier. The glomerulofiltration barrier may prevent the molecules of the protein, the ketones, and the glucose to go out unless there is a problem with the glomerulofiltration barrier or there is an extreme increase in the level of the mentioned glucose, ketones, and protein. Okay? Another, if we talk about food, the most identified as based from the studies that gives strong flavored not flavor that gives strong odor to the urine is asparagus. Okay? So strong flavored foods such as asparagus produce an odor. So expect. So these are the routine observations of the urine. Let us now proceed with the blood. Okay. Usually for the as what I have told you that in the urine red blood cell are not normally contained and detected in the urine. As we have mentioned, the presence of blood in the urine is called as hematuria. The blood in the urine can be distinct by the naked eye or it cannot be distinct visually. So that's why the large volume of blood that can be seen in the urine are called as macroscopic. The one that are undetectable, RBC, undetectable, and can be only interpreted through the use of the microscope is microscopic. Again, macroscopic are large volume of blood that are seen in the urine. It could be visualized by the naked eye. That's macroscopic. Microscopic are those that are not seen by the naked eye and may need the interpretation and evaluation using microscope. So remember class, blood in the urine is not normal, is not expected. However, when we talk about bilirubin and urobilinogen, bilirubin and urobilinogen is not also expected. Okay? Not expected in the urine. Although, as mentioned in the literature, in the usual routine, there could be urobilinogen, but not bilirubin. Remember this class, not bilirubin. If there will be detected bilirubin, the next step that it must be done is to evaluate liver and gallbladder. Okay? So that's why if the client is suspected with liver and gallbladder problems, urinalysis may support if there will be results of bilirubin. And the next step is for further tests to evaluate liver function and gallbladder function. Next, other than the RBC are nitrites. Okay. Nitrites are again not usually found in the urine because and why? The presence of bacteria converts nitrates into nitrite. Kaya if there will be findings of nitrites in the urine, expect really expect a problem or suggestive of urinary tract infection. Okay? Because one thing in the pathophysiology that you may remember, because the presence of bacteria may convert nitrate to nitrite. And nitrite may pass through the urine. And if it is detected, that's an indication of urinary tract infection. Okay. However, as according to DeVille, that 50% of urine samples may contain bacteria. Okay. But nitrites test was negative. So do you mean, sir, that if there will be nitrites, if we expect bacteria, okay, we expect bacteria. For example, there is WBC findings, leukocyte findings in the urine. We expect that there must be no nitrites. Okay? So it means that the bacteria itself, it's part of the urine sample. Possibly it becomes contaminated. But if the result is there is increase in WBC and presence of nitrites, that could support that there is really a problem with urinary tract infection. Okay? So nurses, remember that. Nitrites are not expected with the urine, but nitrites with the result itself may give us the idea of possible and suggestive clinical presentation of urinary tract infection. So that's why it will come to a point of antibiotic therapy, urine culture and sensitivity. So because nitrites are already present. Now, leukocytes. Leukocytes are usually associated with urine, as what I have told you. But remember this, the presence of leukocytes or WBC in the urine is an indicative of severe renal problem. Too much increase of WBC. And however, it could still be supported with nitrites, with the results of the nitrites, then it's very alarming. If the white blood cells are present in the urine and with the pus itself as very obvious and visible, that's what you call pyuria. There's pus in the urine. If automatically, if there is a pus in the urine, culture and sensitivity is always taken into consideration. However, um as what I've told you, bacteria are expected, but not on an extreme level of the results. There are some instances in the results of the urinalysis that there are no bacterial cells detected. And what are those conditions that there are no bacterial cells detected? Those who may have tuberculosis, kasi usually these patients or those may have inflammatory disease of kidneys, usually the patient is said to have sterile pyuria. The sterile pyuria is when the client will be subject for urinalysis, no bacteria have been detected. So remember that's no bacterial cells are being detected. Oh, it's zero. If it's zero, then ask if the client has tuberculosis or has a kidney problem. So it gives us confidence to have a follow-up question so that to support the results or the findings. Next, how about protein? Protein and ketones as well. Okay, proteins and ketones as well are related with each other. Urine does not contain level protein and detectable in the urines, the same as for the ketones, because when the protein passes through the barrier, then passes through the protein and detected in the urinalysis, that's what you call proteinuria. The indication of having proteinuria are those conditions such as clients may have hypertension, clients may have kidney damage, clients may have diabetes mellitus, or clients may have preeclampsia. If you remember what at the time that we discussed drugs with preeclampsia, di ba we have differentiated preeclampsia from a simple hypertension. And we have identified the pregnant client if we have preeclampsia, if there's a hypertension, and at the same time, there is proteinuria. And that supports preeclampsia. So, for pregnant client, then that could be proteinuria. Then for the others that may have proteins, usually the urinary analysis, it may have positive result or detected. Then further test for possible diabetes mellitus, which is somehow the same as for the findings with ketones. So, for the ketones, it could be ketonuria and with the findings of diabetic ketoacidosis, which is suggestive of problem also with hypertension, kidney damage, diabetes mellitus, and pre-eclampsia. How about glucose? Okay. For glucose, again, it is not expected for the findings in the urine because as what I told you, we have the filtration barrier. So the glucose in the urine that occur in pregnancy or patient taking corticosteroids. Okay? So expect glycosuria. So eventually because for pregnant women, because of the physiological changes, for those who are taking corticosteroids, then this triggers accordingly with the regulation of the glucose. So if there is glucose in the urine, that's what you call glycosuria. And if glucose had been detected, it is an indicative of diabetes mellitus or endocrine abnormalities. Okay? So, ketones, proteins, glucose are not expected in the urine. However, if these are detected, then you must evaluate chances of preeclampsia for pregnancy, hypertension, kidney problem, and diabetes mellitus. That's why if there are already detected glucose, the client could be subject for fasting blood sugar so that to specifically identify the blood sugar level in the blood and may determine the level and results chances of risk of diabetes mellitus. Next, let us now proceed with the pH. The pH is referring to acidity or alkalinity. Okay? The normal pH is 5 to 8. And class, always remember that too much acidity, too much alkalinity of the urine is harmful. Why? Too much acidic ng urine of the urine may determine urinary stones. Too much alkalinity of the urine is suggest or indicative of urinary tract infection. Why? Too much acidity of the urine, the acidity level itself may cause formation of crystals and stones. Okay? May cause formation, too much acidity. Next, too much alkalinity itself may cause dryness of the tissues. And if there will be dryness, too much dryness of the tissues, the integrity of the tissues could be risk for the synthesis of microorganisms. And this could be Proteus mirabilis, Klebsiella, Pseudomonas. So remember the pH will determine acidity and alkalinity. Too much acidity, chances of formation of urine stones. Kaya there are some results of urinalysis such as amorphous urates. Those are crystals that may have chances that the urine is more acidic. Okay? So careful. So if it is more alkalinic, high risk for urinary tract infection. And usually class, always remember that too much protein, too much high protein intake will make your urine acidic. Too much or high intake of dairy products and vegetables will make alkalinic urine. So that's why you need also to take into consideration, nurses, that it becomes, on the other hand, it becomes acidic. You will ask the client, do you what is your dietary pattern? Are you more on the high protein intake? So it may have a relationship with the result of acidic urine. If the result of the urine acidity or alkalinity, you may ask the client if there's high intake of dairy products such as milk or vegetables as well. And an indicative of alkalinic urine also is urinary tract infection. So for acidic, as what I've told you, it's more on the urinary stones. Next, specific gravity. In the specific gravity, it will give us the idea if it is diluted or concentrated. Okay? Diluted, it means possibly if too much intake that you have. For concentrated, less fluid that you are taking. So the normal specific gravity is 1.001 to 1.035. However, with the results of diluted urine can be leading to high fluid intake. On the other hand, concentrated urine is a result of dehydration. But if you will notice, diluted urine, kasi let's face it, the urine has color. Yung too much clear and transparent color of the urine is an indication of diluted urine. It may not be, helpful then. Too much calcium, okay, too much calcium itself may lead to diluted urine. Another, if the client may have diabetes insipidus, the problem with diabetes mellitus is insulin. The problem with diabetes insipidus is antidiuretic hormone. If we say antidiuretic hormone, the antidiuretic hormone is the one that controls the controls the fluid. If there is a problem with antidiuretic hormone, there is no control in the fluid. It will just excrete freely, and chances of electrolyte imbalance. So this is a diluted urine. Too much dilution of the urine is an indication of endocrine disorders such as kidney problem or problem with antidiuretic hormone, which is the diabetes insipidus. So these are the last slides of our topic before we proceed. So that is the coverage of the urinalysis. So we will maximize if we could finish at 7 o'clock so that you will still have 30 minutes to review before you process your answering in the self-assessment exercise. So in self-assessment exercise, the coverage only is urinalysis. Let us now proceed. We will now proceed to diagnostic examinations of serum enzymes and isoenzymes. Actually, class, I have included this because this will guide you if there are problems on a specific organ. This will guide you on what specific test can be done. So just like, for example, alanine aminotransferase or ALT. This is former SGPT. SGPT or alanine aminotransferase, these are diagnostic parameters if there are problem with primarily liver. Okay? Although alanine aminotransferase could be present in the heart, muscle, pancreas, kidneys, but moreover, that's why if there is a damage in these organs, why alanine aminotransferase or SGPT is being ordered by doctor? Because the results may validate damage to these organs. Next, prostatic acid phosphatase. Prostatic acid phosphatase is indicated for clients with prostate cancer. But on the state that the prostate cancer is already metastasized. If we said metastasized, the cancer cells have already spread to the adjacent organs. So usually, and we all know that the prostate cancer are for males, and usually the prostatic acid phosphatase or PAP are to check if the results are elevated, then the client, number one, has prostate cancer. Number two, it is already metastatic or metastasized. Next, we have alkaline phosphatase. Alkaline phosphatase or AST as before SGOT. SGPT and SGOT are connected with each other. They are usually being ordered together to test liver damage. Okay? So we have already two, SGPT, SGOT or alanine aminotransferase and alkaline phosphatase for liver. And this could be elevated in bone disease also. So next, creatine kinase. Creatine kinase or CK can be found in the heart and skeletal muscle. However, MM are for muscle, creatine kinase MB is for the heart. So if there are damage in the heart and damage in the skeletal muscle, creatine kinase is the diagnostic parameter. Next, if the client experiences heart attack, to determine a problem with myocardial infarction, which is heart attack, the test is CKMB. Okay? So creatine kinase could be present in the heart and the muscle, but to determine specifically episode of heart attack, such as myocardial infarction, it's CKMB. Next, we have the what we call, how about for those who are having problems with liver brought about by alcohol? Ayan, careful. For those who may have damage in liver brought about by the alcohol, this is the diagnostic parameter, gamma glutamyl transferase or GGT. Okay. So there are some instances that the client may have liver damage and brought about by the alcohol. This is the test. The question, sir, can we use other tests also, such as the SGPT and SGOT? Yes, that could be, because that may also determine damage to liver. Next, how about other lactate dehydrogenase? If there are damage in liver, the heart, kidneys, and lungs, lactate dehydrogenase are the ones that compensates to prevent further damage. So that's why it is elevated. So that's why, again, this could be used in the liver, this could be used in the heart, and this could be used in the lungs also. The succeeding test that I will be talking about is related to tumors or cancer. Alpha-fetoprotein, okay, or AFP, are the tests that to are markers to identify ovarian tumors. Class tumors are abnormal growth of cells. It may be benign or malignant. Tumors are not always cancerous. It must be further tested. So tumors could be benign or malignant. However, for ovarian tumors, it could be done by AFP and liver tumors. For intestinal tumors, it could be the carcinoembryonic antigen or CEA. And for the recurrent prostatic cancer, it's PSA or prostate-specific antigen. The PAP that we mentioned a while ago in the previous slide is a test for prostate cancer for prostate cancer that has metastasized. But if the prostate cancer has recurrence, what do you mean by recurrence? The client have recovered from prostate cancer, then at the same time, it occur again the presence and evidently of the prostate cancer, then the PSA is being identified. So this is the last slide. I have integrated this test as COVID-19 because this must be oriented to all of you. Remember class that in the COVID-19 test, the reverse transcription polymerase chain reaction or the RT-PCR test is considered as the gold standard to detect the presence of COVID-19 infection. It's the gold standard. Ibig sabihin, the primary reference to really identify presence of COVID-19 infection. However, we have the rapid testing. Okay? The three rapid testing may not be the gold standard, but it could help. Rapid antibody testing. Rapid antibody testing could not be a gold standard because it may give false positive and false negative results. Why? Because, for example, if the client has already the COVID virus and it will take 90 days and he or she is asymptomatic, even though recovered, the client could still be positive through the antibody because the antibody had been established in the body. So it could be on the letter B. The rapid antigen testing is the one that is used to detect active COVID-19 infection if it is active. Okay? The RT-PCR is the gold standard. The rapid antigen is to detect active. So that could be the second alternative. Next is the rapid genetic testing is indicated on the screening and confirmation. Remember class, at the time that the variant had been uh, uh, presented in the news, and to significantly identify who among who among the who among the members or the persons had been afflicted or contracted with a certain variant, the rapid genetic testing is the one that is being used to specifically identify the specific variant of the COVID-19. So I think this is the last slide on our topic for today. So I will end up my screen for further instruction and will stop my recording as well.